A las familias que quieran comentar algo en televisión o a los niños que les dije a esa hora para que estuvieran también los niños, ¿vale? Las familias que quieran salir, pues que sepan que a las 6:30 va a estar la televisión, espero que esté allí, ¿vale? Pues me lo tienen que confirmar, pero bueno, para que todos hagáis vuestros planes.
Entonces, dicho esto, vamos a comentar o vamos a continuar con las ponencias de la mañana de hoy y le toca el turno a Alan Percy. Alan Percy es doctor y profesor y director también clínico del síndrome de Rett en la Universidad de Alabama, en Estados Unidos. Alan Percy es el investigador principal de todos los estudios que se hacen en esa universidad en relación al síndrome de Rett. Es un científico que está muy comprometido en buscar una solución al síndrome de Rett. Y el título de su ponencia es Estudio de la historia natural de las enfermedades raras, cómo proveer de ayuda en los ensayos clínicos. Cuando quieras.
A fine gathering here in Spain. We'd like to see everyone in the world embracing Rett syndrome and engaging in understanding and working together as families, because that's how we can make progress. What I'm going to talk about is a fairly dramatic shift from what you've heard already this morning, going back to the clinical picture of Rett syndrome. You've heard this before, but these two gentlemen are really what put Rett syndrome on the face of the earth. With Bengt Hagberg during two sessions that I spent in sabbatical, the second one and the first one in medical school, a very long time ago, and before I even knew about Rett syndrome. They are both fine gentlemen, were fine gentlemen, and unfortunately have departed this earth. This is the paper that Bengt and his colleagues wrote in the Annals of Neurology in 1983 that really put Rett syndrome on the map and became known internationally. It is interesting to me that Bengt had already begun writing this paper along with his colleagues around 1980 or 81, and when he had a chance meeting with Andy Rett, and after that meeting he went back to his colleagues and said, we should call this Rett syndrome. I'm going to talk about natural history studies, and this has to do with treatment, because both the Food and Drug Administration and the National Institutes of Health really pushed the gathering of data on the longitudinal progression of the clinical events associated with Rett syndrome to understand what happens naturally, so that when we engage in clinical trials, we can know that the effects that we see are actually those related to the agent and not related to the course of the illness. And of course, we don't want to see a decline in function either from the clinical trials. So we started this natural history study in 2003. It was fostered by the National Center for Advancing Technology, Translational Sciences at the NIH. It was based actually on legislation in the United States that came long before that, and the Congress told the NIH they needed to focus on rare diseases. Rett syndrome is a rare disorder. There are 7,000 rare disorders or so. Most of them are genetic in origin. But when you take all of the individuals involved, it's 25 or 30 million people in the US, which is a substantial amount of the population. Therefore, it represents a major public health issue and it's something that needs to be dealt with by government. So we started this study in 2003, and by the rules that we had to follow, we had to engage in 3 different disorders. And we selected Angelman syndrome, Prader-Willi, and Rett syndrome. And they are linked in some ways through their genetic mechanism. Different genes, but their genetic mechanism. We continued this for a further 5 years with a resubmission. And when it came to the 3rd resubmission, we made a decision that we would focus only on Rett syndrome-related disorders, or disorders associated with MECP2, but not Rett syndrome. So this simply summarizes what we are doing in the current clinical trial. The major study continues the longitudinal study of individuals with these disorders. And so for many of them, we have seen them now for more than 10 years and have multiple visits. And we see these people, these children and adults directly. This is not a sign-in, fill out a questionnaire. Depending on their age, in the first iteration we saw them once or twice a year, and now we see them again, depending on age, every year or every other year. The second study that we are doing is an advanced study of auditory brainstem evoked responses and visual evoked responses to understand how the messages that come through their auditory or visual system, how they are translated to our ideas or their ideas of what they either hear or see. Then we are engaging in a biomarker study where we're collecting blood, skin, samples from saliva, and perhaps other tissues as well to advance various studies in girls with Rett syndrome or other individuals with FOXG1, CDKL5, or those individuals who have mutations in MECP2 yet don't have Rett syndrome. And further, we're very, very interested in boys and their mothers, particularly who have MECP2 duplication. We also are engaged in pilot studies. One is to develop a robust emotional outcome measure. We don't have a good outcome measure and for clinical trial for behaviors, and we know that that's very important. Secondly, we're looking at a metabolomics approach, looking at all of the chemicals in your blood to see if they are in any way altered by the MECP2 mutation and subsequent effects. And then we are looking at sort of autonomic profiles by using wearable devices. There's a wristwatch that can do blood pressure, EKG, heart rate, respiration. They're working on detecting seizures. That's one device. There is a second type of device where you put markers on the skin and collect similar information. So what have we learned from these natural history studies to date? Well, quite a bit. You can see that we have had, through the first studies, enrolled over 1,200 individuals. More than 950 had classic Rett syndrome. Another roughly 15% had atypical Rett syndrome. And the remaining girls had either mutations in MECP2, or there were some boys with MECP2 mutations, including some of their mothers. For classic Rett syndrome, more than 95% had mutations of MECP2. And we know that there are multiple mutations in this gene. The numbers are perhaps subject of questions, but there are more than 300 different or unique mutations in this disorder. But 8 specific point mutations make up about 60% of the total. You've already heard that T158M is very common. The R168X is also very common, and in different populations, those two kind of shift between the first and the second. And the least common is the R106W of these 8. But there are other mutations, point mutations, that occur less commonly, but are in a number of individuals. We also have girls that have deletions, missing whole segments of the gene and the protein, but these are not whole exomes, but relatively small sections of DNA or amino acid. And they make up 15 or 18% of the total. So when you add those two together, 80% or so have these two groups of mutations. And all the rest happened relatively few girls. In some cases, only once. The mutations are mainly sporadic. They are ordinarily de novo. They're not inherited. They are genetic. And they occur in rapidly dividing germinal cells. And those are the sperm, not in the eggs. That's why most of these girls arise from mutations that occur in paternal sperm. It's very important that fathers not blame themselves, because they have no control over this. Absolutely none. Familial Rett syndrome is very uncommon, but it does occur, and the families that have had Rett syndrome through multiple generations have been were very instrumental in understanding the mutation, the origin of it, but also in understanding some of the variability between the males and the females. Variant forms, as I said, represent about 15% of the total, and of that group, about 75% have mutations. We now have in Natural History Study 3 almost 600 enrolled, and we're enrolling roughly 40 per month. So it's an ongoing, rapidly developing process. Paige mentioned yesterday that we started with 4 clinics. We actually started with 3, and we added a 4th clinic in the second study. And as a result of the location of those clinics in the U.S., they were all on the East Coast or in the South, which meant we missed a whole lot of the population. So we developed travel clinics where we went 8 times a year to 4 different sites, and we enrolled patients from Oakland, Chicago, New Jersey, and in Florida. Florida's a long state, so we had 2 different sites in Florida, one in the winter, one in the summer. We picked it wrong time, though. We didn't go to Miami in the winter. We went to the summer. But now, because of these clinics, we have created an additional a total of 14 clinics throughout the U.S. So we don't any longer do the travel clinics. So these are the diagnoses that are as of the end of June of this year. You can see, I'm not going to read them all, but we have classic, atypical, MECP2 duplications, FOXG1, CDKL5, and those are the percentages of that they represent among these girls at that time. So what have we generated? We have a lot of information, but I wanted to focus on these several points here. We know a great deal now about growth and development, epilepsy, breathing dysfunction, scoliosis, sexual transition or maturation, longevity or survival, phenotype-genotype correlations, clinical severity, and we use that clinical severity very closely and carefully because it is a range, and it was mentioned earlier about stratification, and we use that clinical severity scale to stratify girls in clinical trials, so when we match a girl, two girls with the drug and the control, we are matching girls with similar degrees of difficulty, even though they may have quite different mutations. And we have quality of life assessments that were greatly enhanced by requirement that the FDA had, and so the NIH made us do these. These are off the shelf, not specific for Rett syndrome, but they've turned out to be quite useful, and I'll mention those later. So for developmental skills, we know that most of the girls acquire developmental skills, but they're late. So sitting, walking, picking up objects, saying a few words are generally acquired, but often late. More complicated skills, such as riding a bicycle, climbing, running upstairs, running at all, are slow to develop and may not develop at all. The clinical severity isn't stable. It tends to increase slowly over time because these girls go through changes in muscle tone or flexibility, much like Parkinsonism, so that these skills deteriorate. Certain of the mutations have a better outcome, and we just talked to a father of a daughter with R294X, and that is a mutation which tends to have a better outcome. Not normal, but better. Growth. Small stature is typical. It's not 100%, but it's very typical. So these girls rarely exceed 40 or 50 kilograms, and they rarely are taller than 140 or 150 centimeters. The head circumference ordinarily, not completely, but ordinarily goes through a period of abnormal deceleration after the birth, and this can be detected as early as a month and a half or two of life. And the 50 percentile line for the girls with Rett syndrome crosses the second percentile line in the normal female population in the US around age 2. We have similar features for height and weight. Weight is often a problem. Weight gain is a problem. Feeding is often a problem, particularly prior to the onset of menstruation. After that, the girls tend to gain weight. So we are pushing very hard to gain weight for the first part of their lives, and then we were slowing down so they don't gain too much weight afterward, because for your parents, lifting 50 kilograms can be very, very tough. You have to do that multiple times a day in many cases. Epilepsy. This is probably a major concern for many people. It is present overall in a vast majority of the girls, but it goes through a cyclic pattern. So that, let's say, by age 16 or 20, 85 to 90% of the girls will have had seizures requiring medications, but at any given time, if you take a point in time, only about 35 or 40% actually require medication for treatment. But then the seizures may come back at some point in time, and I'll show you a graph of that. Sometimes it's difficult for clinicians to figure out what a seizure and what is not a seizure. And so many times when these events occur commonly, and that is multiple times per week, we recommend video EEG, so you get an actual picture of what the girl is doing at the same time that the EEG is being recorded, and you can time lock the event. And in many cases, we find that the events that the parents are seeing are not seizures. They're probably coming from the brainstem, so they're not normal, but they're not seizures, and they won't respond to traditional medications for epilepsy. unfortunately, I can't see the slide from here very well, but on the left is those children who didn't have seizures at all. And the dark blue and the light blue, those are children who may have had seizures and they stopped completely. And then in the next 3 bars are individuals who had seizures, they stopped, they started, they stopped. And then in the final bar are the girls who had seizures that were present when we first enrolled them, and they continued to be present throughout the study. So this is a pattern that is seen, I think, probably throughout the world. Awake breathing rhythms are very, very problematic, probably even worse than seizures in the terms of effects, because they may involve almost 100% of the girls. The major period of breathing dysfunction is between 5 and 15 years of age, but they can occur at 2 and they can be present in 35 and 40-year-olds. Remission does occur, and total remission was seen in a relatively small percentage of the girls. These breathing patterns are associated with poor motor function, worse hand stereotypies or seizures, abnormalities in the cardiac conduction in a small percentage, and caregiver accounts of concerns that this could lead to further illness, if not to sudden death. There's lower presence of the breathing abnormalities with better weight gain and with fewer seizures and with better head circumference. And this is the pattern that we see for breathing abnormalities. So roughly a third or so have this waxing and waning on back and forth periods of abnormalities in either breathing fast or holding their breath. And then the larger group in all red had breathing abnormalities throughout the study. Now, scoliosis. This is a concern, again, for a majority of the girls with Rett syndrome. It occurs already before children go to school. It's present in a significant number of individuals by the time they reach age 8, and by 16 to 20, it's pretty much maxed out. Ordinarily, after the girls go through menstruation, the progression ceases. Ordinarily, not completely, but it usually stops. We have a pattern of selecting girls who have curves that are greater than 20 degrees or 25 degrees, and we may suggest the use of a body jacket or a back brace. There is no specific study in Rett syndrome that shows that the back brace is effective, but it has been done in children with cerebral palsy and been shown to be effective. So it may not retard the progression completely, but it will slow it down and may get you through the period of menstruation. In our study, in the second study, almost 20% of the girls have had surgery, and the parents, by and large, almost to a complete total, are very supportive of the effects of the quality of life for their girls. I mean, if you imagine that you're looking at the world like this and now you're back up straight, just that alone is a better way to look at your environment. Phenotype-genotype correlations. We know that these 4 specific mutations are associated with better outcome. And those other mutations, there are several, plus some larger deletions and insertions, are associated with poorer outcomes. The clinical severity is generally, again, going to increase with age, but it is very supportive of these results. And the children who continue to walk, to use their hands in some way, and to have a later age of onset of their regression tend to do better. However, there are certain caveats that you need to understand with this. Two girls with exactly the same mutation may be completely different. And why is that? Well, one is a factor known as X chromosome inactivation. Girls have two X chromosomes, and the degree of inactivation is not always random, not always 50-50, like flipping a coin. In fact, we did a study on blood as a surrogate measure of X inactivation in the brain and showed that a very significant number had highly skewed values. That is, more than 90% of their X chromosome was coming from one or the other, or there might be two, one or the other of the X chromosomes. Interestingly enough, it was divided equally. About half of that group had worse outcome than would be expected, and about half were much better. There's also the issue of genetic background. All the other genes that are in this family, in this child. And then there's a phenomenon that's rarely discussed. Actually, Janine LaSalle, and I don't see her, but she's going to talk later. And she actually had a study showing, I see Janine, showing that there was actually a clonal distribution of the abnormal and normal X chromosome in the brain. And it's probably true in humans. We can't study that, but it's probably true. And then finally, the environmental influences are very, very important. Sexual maturation occurs prematurely in a substantial number of girls, but if you notice that the median age, or the time from breast development beginning to onset of periods, is almost 25% longer in girls with Rett syndrome than in the normal population. The age at menarche, or period onset, is about half a year later than in the general population as well. Ordinarily, breast development is either synchronous with pubic hair development or precedes pubic hair development. And in Rett syndrome, you can see it's reversed. So adrenarche is actually breast development, and thelarche is pubic hair development. Those girls who had better BMIs, better weight to length, were also going to have early puberty, and milder mutations had earlier periods. Longevity, this study suggests that the survival is above age 50 in more than 50% of the girls, slightly above. It's obviously not the same as the normal female population, but it is better than the original group of Andy Rett, which was about age 25. We have looked at subsequently in our study and reaffirmed these values with the survival. And then in even later study, when we looked at survival and effects of which might be related to premature death, we found the same survival beyond age 50. Cardiorespiratory, heart and lung issues were the main causes of death. And the extreme frailty, the very, very small size, and the severe contractures that were present before 1990 or up to 1990 as reported then, we didn't see at all. So this really reflects the impact of the parents on making certain that the nutrition is better and the therapies are better to prevent these secondary changes from occurring. Quality of life, we did the CHQ for the children, and we could show that there is a definite association between motor function and mental or behavioral function. So those girls with poor motor function actually have very good behavior. They're quiet, they don't raise a fuss. Those girls with better function or ambulatory, they can cause some concerns for parents. They can climb on the furniture, turn on the water, get to the stove, pull something off the stove, and we even had a girl who got out of the house and was hit by a car. So the question is then for clinical trials, if we made some slight improvement, would we get to a level of better motor function but worse behavioral function? So that is a concern. The parent quality of life is quite similar. Initially, the mental health of the parents was lower than physical health. But as time went on, the physical health went down, and maybe they accommodated to the situation, and their mental health actually improved. So that's a very, very important part of that and the subsequent clinical trials. And the changing face of diagnosis. Diagnosis was often delayed in the U.S. You heard Paige mention it's about 2.5 now. This study showed 2.7 years, but it is improving because we've seen girls now less than age 2 for diagnosis. In the U.S., subspecialists make the diagnosis 90% of the time. So that's pediatric child neurologists, developmental pediatricians, or geneticists. I saw a paper that I reviewed from the United Kingdom, and it was absolutely the opposite. The primary care physicians in the United Kingdom tend to make the diagnosis. That's probably good, because in the U.S., we think that you ought to be able to make the diagnosis earlier than 2.5. And since pediatricians are seeing them, and we are not, maybe they could respond to these clues. A declining head circumference. It's not the only disorder associated with declining head circumference, but it ought to turn on a light bulb. There's abnormalities in development. When a parent says, I'm concerned about the development, the physician needs to respond and not say, oh, just wait a couple months, maybe it'll just a plateau. They need to respond. And then many times the girls are really good babies, maybe too good. And so when the parents see that, they should respond and talk to their physicians. So in clinical trials, these are absolutely critical. We have disease-altering or modifying treatments. We have gene therapies that have been talked about. I personally believe, I know you heard something different yesterday, but the earlier you have the diagnosis, the earlier you can treat. Not saying you shouldn't treat older individuals, but I think that the impact would be greater the younger the age. That's just my thought. The support of you, the families, is absolutely critical. If your support or all family support is lacking, the pharmaceutical companies are going to lose interest, and then we've lost the game. So we've made pretty good progress over the past 50 years. We have general recognition of the disorder about 30 years ago. Mutation was identified 15 or 16 years later. Remarkable progress in biochemical or basic science and clinical science. Translational studies have progressed, and now we're coming full circle back to the clinics, and we're approaching treatment in individuals. And the role of a cure is at least being discussed, and I would support that tremendously. So what does the future hold? We need the continued work of basic and clinical scientists in this regard, but it requires more than that. I mean, you must have a support of industry, support of the government, support of advocacy agents throughout the world, and particularly individual families. It really demands patience and courage, focus and understanding, and a collective will to succeed. Now, this is the first girl I saw in Houston in 1983. She's now about 38. She's had scoliosis surgery. She still walks around. She's remember I talked about environment. She lives in a pretty good environment, and she does remarkably well. So thank you.